Welcome to the electrolyte lecture for April CME. Today we're going to discuss how some of the key electrolytes alter this cardiac cycle and why they're important for us as clinicians to understand, interpret what they mean. We are also going to take a look on how they are going to appear on an ECG tracing and the possible treatments and what actually causes these imbalances. There are four main electrolytes that are involved in a complete cardiac cycle. These are sodium, potassium, calcium, and magnesium. Each of these play a vital role in how an ECG will look. Any imbalance in one of these will display a unique tracing on the ECG, some of which can cause deadly arrhythmias and are commonly seen in the field. The term hypo means low, so if there is a hypo in front of an electrolyte name, it means that the levels in the body are below the normal range. The opposite of this would be an electrolyte had hyper in front of the electrolyte name. This means there is an above normal range of electrolyte in the body. Now that we have a little more familiarity with these terms, let's review the actual electrolyte names as they will appear with hypo or hyper in front of them. The first electrolyte we're going to discuss is the most basic and one we're all most familiar with, which is sodium. Sodium, when referring to the levels in the body, is called natremia, and the normal limits of sodium are between 135 and 145 milliequivalents per deciliter. The second electrolyte is potassium. Potassium, when referred to in regard to the body's levels, is called kalemia, and the normal values for this is between 3.5 and 5 milliequivalents per liter. We will pay special attention to this one later in the lecture. It has a very small range and is common to see in some of our sicker patients. The next electrolyte is calcium, and this one actually looks like the word when represented by the levels in the body. It is referred to as calcemia and has a range between 8.5 and 10.5 milligrams per deciliter. This also has a very small range and has a major effect on how an ECG tracing can appear. Lastly is magnesium. When referred to the levels in the body, it looks like its original name as well and is called magnesemia, and its values are between 1.8 and 2.5 milligrams per deciliter. Although the actual numbers may seem unimportant to us as clinicians, we all recall when we were dispatched to a nursing home for a patient with abnormal lab values. As routine as this call may sound, as we review throughout this lecture, we will find that if the values are off and these lab values are out of whack, we may have a very, very sick patient on our hands. So let's review some of what we have learned at this point. If I asked you to tell me what does hypocalcemia mean, you would say, I'm sure everyone out there said there are low levels of calcium detected in the body. Great job. Let's try one more. If I asked you what hyperkalemia means, what would you say? Again, I'm positive everyone said that there's high levels of potassium detected in the body. Now that we have some of the basic terms and definitions down, let's dive into the four electrolytes that display on an ECG and some of the signs and symptoms of these abnormal values. Hyponatremia. I hope everyone's first thought was low sodium levels in the body, because this term is used when the sodium levels fall below 130 milliequivalents per liter. The acute phase, and possible reason we as EMS providers may be called, happen within the first 48 hours. One of the most common reasons for hyponatremia is a massive fluid shift in the body. Although this is well tolerated in the body, the brain is the most sensitive to this shift. A false positive, however, can be someone in a hyperkalemic state. The extracellular glucose accumulation causes the free water into the extracellular space, resulting into hypernatremia. This, however, is not a true osmolarity shift. When the hyperglycemia is fixed, the levels of sodium will return to normal. Some other signs and symptoms may include cerebral edema, headache, nausea, vomiting, seizures, difficulty concentrating, confusion, lethargy, and muscle cramps. For acute hyponatremia, like we discussed, within 48 hours, the cardiac findings are minimal to an extent. It will depend on the severity of the shift and how fast it was. If it is too quick, the patient will go into cardiac arrest due to brainstem herniation / cerebral edema. You can also see AV heart blocks, which we would treat according to our mom's local protocols. But predominantly, it will be physical findings as mentioned. The more common findings will be in chronic hyponatremia. That could be a wide variety of medications included, over-the-counter medications, such as Motrin. Treatment for this patient will be treating their symptoms closely and monitoring for any cardiac dysrhythmias. As mentioned, anything with hyper in front of its name means elevated levels. So as we talk about hypernatremia, this means elevated levels above 145 milliequivalents per liter, and again has more severe signs and symptoms in the acute setting. These are very common symptoms when we're talking about hyper, as we talked about hypo. So for instance, mental status changes, lethargic, delirium, coma, irritability, confusion, and increased muscle tone. This is considerably less common finding than hyponatremia. The ECG will very rarely display any type of significant changes. The body will become thirsty to correct this problem, and unless able to get water, the hypernatremia will be fixed on its own. The elderly may be more susceptible to this abnormality, especially if they are found on the ground for a few days and unable to drink any fluids. Hyper/hyponatremia may be some of the root causes for our altered patients that us as clinicians can't seem to figure out. These are hard to determine in the field, but worth a review as we move on to our other electrolyte imbalances. The next two electrolytes we're about to discuss have very specific ECG changes, so let's talk about them. So now let's talk about hyperkalemia, which, as you probably have already guessed, is high potassium in the blood. Hyperkalemia levels in the blood over 5 milliequivalents per milliliter define hyperkalemia. Hyperkalemia is presented commonly in our renal patients. In mild to moderate cases, some physical findings can be general weakness, burning or pricking sensation usually felt in the hands, arms, legs, and feet. This is also referred to as paresthesia. And fasciculations, which means muscle twitching, also happens in the extremities. There are three common disorders associated with hyperkalemia, which include increase in potassium intake. A fun fact, if you ate roughly 42 bananas a day, you could make yourself hyperkalemic. So we're referring to a little bit more when we talk about oral intake than just bananas. Potassium-containing medications like penicillins can also increase your potassium levels, though as well as massive transfusions. Transcellular shifts can also cause hyperkalemia, and this is seen in our DKA patients, drugs such as digoxin and succinylcholine. Also, in our burn patients and crush syndrome patients. Ever wonder why we treat a diabetic in cardiac arrest with sodium bicarb and calcium? The kidneys, due to the patient having such high sugars and being insulin deficient, causes the kidneys not to excrete potassium properly. The last common reason is, like we discussed a few minutes ago, is our impaired renal function patients. So, how is this going to present on our ECG? As we take a look, the ECG behind me, you will notice that as the potassium levels increase, the more of the ECG becomes unrecognizable. As we take a look, you can see the stepwise fashion the ECG develops as the potassium increases. Notice the shortening of the QT interval, the symmetrical T wave peaking, QRS prolongation, shortening of the PR interval, and the P wave flattening. If this is left untreated, patient's ECG will become what is known as a sinonodal pattern. This is also referred to as a sine wave and results from the fusion of the QRS wide complex with the T wave. A good example of this is the last ECG shown on the slide. If the patient is in cardiac arrest, follow the current MOM protocol C1. If the previous mentioned ECG changes are noticed and the patient is symptomatic, a med consult is required to give the following medications. Calcium chloride 10% should be one of our first treatments to patients who have widening QRSs due to hyperkalemia, and a patent line established. Sodium bicarb would be the next drug to lead the shift of potassium into the cells as hydrogen ions shift extracellularly. Make sure we have another line established before we give sodium bicarb and calcium together. This should never be given in the same line. Next drug up, albuterol at high doses of 10 to 20 milligrams can aid in the shift of potassium intracellularly via beta-2 receptor stimulation. The final piece to this treatment is insulin. I know we don't carry it on the streets, but it also stimulates the sodium-potassium pump activity by causing intracellular shifts of potassium and sodium. The most common cause of hyperkalemia seen in the emergency department is a renal patient who has missed their dialysis. So, Let's make sure we take the patient to the hospital that has the capabilities of emergency dialysis. Hypokalemia is our next topic, and I'm sure by now we have the terms and definitions down. So, hypokalemia is low potassium in the body, and its range is below 3.5 milliequivalents per liter. Some cases that may be seen in the field are eating disorders, people who are fasting, people suffering from alcoholism, and people on diuretics. Some other causes could be people taking penicillin, lithium, steroids, cisplatin, which is a chemo drug, and aminoglycosides, which is primarily used for treating a severe infection. There are other reasons as well people could be hypokalemic. Nausea, vomiting, diarrhea could also play a role in these low levels of potassium. Increased insulin, either by accidental injection or the body overproducing it, profuse sweating, burn patients, people with fevers, all could be hypokalemic. These are just a few of many reasons why hypokalemia can occur, but some of the more common reasons we may see in the field as EMS providers. You notice the slide behind me is showing a normal ECG with potassium within its normal ranges. Everything looks normal, upright as it should be. The ECG below it is displaying hypokalemia with a prolonged PR interval, a slightly peaked T wave, ST depression, a shallow T wave, and a prominent U wave. The T wave may continue to flatten out, and a prolonged QTC interval may appear. Reading and understanding these ECGs does and will take some practice, so give yourself some time and have patience while learning. Hypokalemia, if the levels fall below 2.5 milliequivalents per liter, severe dysrhythmias may occur, which include VFib due to prolonged refractory period. Hypercalcemia is high levels of calcium in the body, and it is considered elevated when the levels are above 10.5 milligrams per deciliter. Now, this is a clinical definition. However, vague symptoms don't start until 12.5 milligrams per deciliter. These symptoms include depression, fatigue, and cognitive changes. As these levels increase, more GI symptoms are noticed like nausea, anorexia, constipation, and abdominal pain. There are numerous causes and disease processes that can display hypercalcemia. The most common asymptomatic patients who are ambulatory may have hyperparathyroidism. To remember all of them would be a challenge. So let's take a look at some of the common medications that we could see that could cause hypercalcemia. These include vitamin A and D supplements, antacids, lithium, and thiazide diuretics. These are just to name some basic ones we may see in the field on our everyday calls. Well, we have one tool in the toolbox to treat hypercalcemia. Some of you out there may have guessed it already. If so, let me catch the rest of us up. If you were thinking normal saline, then you guessed right. This will help re-expand the extracellular space and enhance calcium excretion. 1 liter should be given at minimum to start. Caution should be given, like every other time we give volume of fluids, with our cardiac and renal patients in regard to potential fluid overload. So reassess lung sounds often, and of course, observe your patient for any signs of increased work of breathing. Hypocalcemia's clinical definition is a serum calcium level below 9 milligrams per deciliter, and severely low is considered anything below 7 milligrams per deciliter. The hallmark sign for hypocalcemia is neuromuscular irritability, and there are two classic signs to go over. The Chavosky sign is when there is facial muscular twitching after percussion over the facial nerve in the preauricular region. You're probably sitting here asking yourself, what the heck is the preauricular region? Well, glad you asked. It's the area right in the middle of your ear, right here. The Chavosky sign is presented by carpal spasms after inflating a blood pressure cuff above the systolic pressure for 3 minutes. In conjunction with a good history taking and ECG presentation, hypocalcemia may be suspected. Now, I mentioned a good history taking previously for a reason, and here's why. Some of the causes for hypocalcemia are in the patient's history. For instance, parathyroid hormone insufficiency, autoimmune disorders, magnesium deficiency, which we'll discuss in a few minutes, vitamin D deficiency due to hepatic or renal disease, and malabsorption such as IBS or gastrotomy. Getting a good history can lead you down the correct path for success with the patients, especially in hypocalcemic patients. Among many other conditions, there are just some highlights that EMS may see. Hypocalcemia patients, I think we all can agree, need calcium. This system carries calcium chloride 10%, and we would need a med consult to do so. Follow CS1 for proper procedures for this. If granted permission to administer, some cautions administering this medication are noteworthy. First and foremost, a large patent IV is needed. We need to make sure there is no infiltrations that may cause thrombophlebitis or basically a clot. Burning at the site may occur, and like with any other administration of calcium, sodium bicarb, if used, has to have its own dedicated IV for that. This is high levels of mag in the blood above 2.5 milligrams per deciliter for the clinical definition. However, signs and symptoms won't start until anything above 4 milligrams per deciliter. Hypermagnesium results in the neuromuscular depression by inhibiting acetylcholine release at the neuromuscular junction. The elevated magnesium levels can act as a calcium channel blocker as well, so cardiac effects may be seen related to this block. Hypermagnesemia is uncommon unless in the presence of a renal failure patient or someone who has been recently treated for preeclampsia. Acute renal failure patients have GI absorption issues despite the elevated magnesium levels in the body. Some of the over-the-counter medications that can cause hypermagnesemia are Lasix and antacids. The typical non-renal patient that has hypermagnesemia are the elderly patients taking a narcotic or an anticholinergic and trying to treat constipation with laxatives. Early cardiac presentation can be bradycardia and hypotension. Obviously, treat these according to the most appropriate protocols. On the actual ECG, you may see something like what is displayed behind me. The PR and QT interval will be prolonged, flattening P wave, and the QRS duration may be increased. A tall peak T wave may be seen, and as the mag levels increase in the body, you may see further cardiac issues such as complete heart block due to the severe effects of increased mag on the calcium channels. Giving the patient calcium will drastically help reverse the severe toxicity of mag. This again will be a medical consult following CS1 guidelines. Fluids will expand the extracellular space, and I know we don't carry it, but Lasix will help the body excrete the abundance of mag. If the patient, as discussed earlier, is in a heart block or bradycardic and symptomatic, treat according to CS4 in the MOMS. Hypomagnesemia. Last, but certainly not least, hypomagnesemia is when the body's mag levels drop below 1.5 milligrams per deciliter. What makes this so important and ties this whole lecture together is what the signs and symptoms are. This imbalance rarely occurs by itself, and it almost always is associated with other imbalances in the body. These are Hypokalemia and Hypocalcemia. The low calcium levels will remain refractory until the low mag levels are fixed. Early signs of hypomagnesemia are nausea, vomiting, fatigue, lethargic, and weakness. All these electrolytes work together, and some lean on the others very heavily. So what causes this imbalance, do you ask? Well, like the other electrolyte imbalances, there's a lot of possible causes. For this discussion, again, we will focus on common things EMS personnel may see, like chronic alcoholism can cause this, diuretic use, and drugs that are toxic to the renal system. Some of the drugs include loop diuretic, cisplatin, the chemo drug mentioned earlier, and those are just to name a few. There are multiple intestinal problems including IBS, vomiting, diarrhea, and the use of laxatives and malabsorption syndrome. There are many other syndromes and organ issues that may cause hypomagnesemia, so a good patient assessment and history taking and listening to the loved ones may help you with and understanding their current medical condition. Hypomagnesemia has some pretty deadly dysrhythmias associated with it. This includes ventricular dysrhythmias. One commonly seen is torsades de pointe. The other ECG findings are Hypocalcemia and Hypokalemia associated with this, as mentioned earlier. The ECG on the slide behind me shows the prolonged QT interval and again the classic torsades de pointe, which as a reminder also means polymorphic VTAC. The treatment for hypomagnesemia is treating the dysrhythmia found according to C1 protocol. Thank you for listening and have a good day.